Okay, folks, so here we are to start this next chapter on articulations. And if you're following along, we just finished the bones. So wouldn't it make sense after the bones to talk about joints? Remember, joints and articulations are the same thing. Articulation is just a fancy name for joints. So wouldn't it make sense after we just finished talking about bone that we're now going to talk about how the bones come together to form joints? Great. So the goal of this first lecture is just to go over the types of joints, where we find them in the body, what motions are available at those joints, and then a couple other introductory things. And then when we meet next Thursday for lecture, we're going to talk about the more specific and the harder stuff. So we'll talk about lever systems and then the load deformation curve for ligaments. The fun will continue. Cool. Also, now that you've seen what an exam is going to look like, you should be all the more better at taking notes, figuring out kind of what to study, which is, of course, whatever we're talking about, right? Alrighty. I just took a sip of the water here. I apologize. So I'm following along in the notes, and there's two different ways to classify joints. We can classify them functionally, or we can classify them structurally. So let me just, because I don't think I have it quite that well here. So let me just start with this to make it easier. So we can do a functional classification of joints, like types of joints, a functional classification, or we can do a structural classification. I prefer to do the structural, which would be fibrous, cartilaginous, synovial. So what we're looking at here are the types of joints as classified by structure. This is how we're going to do it. We're going to discuss joints as being either fibrous, cartilaginous, or synovial. This is my preferred method, and I think you're going to agree with me in a moment. The other way to classify the joints is the functional one, and that would be synarthrosis, amphiarthrosis, and diarthrosis. That's the more specific term. So I'll just write them down here, even though you aren't going to have to know these. So the functional way to classify joints in the human body would be to label them as either synarthrotic, amphiarthrotic, or osis, and diarthrosis, or diarthrotic. By the way, these mean the same thing. A diarthrosis is also a synovial joint, an amphiarthrosis joint is also a cartilaginous, and a synarthrosis is also a fibrous, but we're not going to go by the functional terms. So therefore, you don't need to know those. We're going to look only at the structural. Here we go. And this should be a review from anatomy and physiology. A fibrous joint is a joint that is immovable. So it's two bones formed by fibrous connective tissue, but it's immovable. Immovable. It's still a joint because it's where two or more bones come together, but it's immovable. An example of this would be the sutures of the skull. And that's what the picture is. There was the coronal suture. There was the squamosal suture. There was the sagittal suture and the lambdoidal suture, where the bones of the skull connect. It is a joint, a fibrous joint. It is immovable. And be able to give an example. Easiest example is the sutures of the skull. Then we have a cartilaginous joint, which, as you can guess, is a joint where bones are connected by cartilage. Actually, I'm going to put that up top here, save a little space. A cartilaginous joint is a joint where bones are connected by cartilage. That's not so hard. So that's why it's called cartilaginous. We can see one example here. This is the joint between the rib cage and the sternum. The two places in the body that we think of would be the joint between the rib cage and sternum. Sometimes when I ask this question on exam, people will write as an example ribs. And if you just say ribs, that's just the bone. Ribs is just the bone. You got to give me the joint. Joint between the rib cage and the sternum. Right? Or you could say the pubic symphysis. This is the joint where the two pubic bones of the pelvis come together anteriorly. But both of them are where joints are connected by cartilage. So here's the sternum, here's the rib cage, bones are connected by cartilage. What type of movement is permissible here? It's not necessarily flexion or extension or abduction or adduction. It's more about flexibility or give. Think about the rib cage, the joint between the rib cage and the sternum. Every time we inhale, our rib cage expands. How is it able to have this expansion? Because of this piece of cartilage. So it doesn't necessarily give gross movement you can see with your naked eye, but it does allow for a little flexibility or give. And then lastly would be the synovial joint. This is what you think of probably most often when you think of a joint. By definition, sorry for the pause there, by definition, a synovial joint is a joint with a cavity filled with fluid. Fluid-filled joint. Fluid-filled joint. Fluid-filled joint. These are what you think of. Elbow, wrist, knee, hip, shoulder, metacarpophalangeal, distal interphalangeal, really all the joints that are freely movable. These are freely movable. We can do all sorts of things. Sometimes we can flex and extend, or abduct and adduct, or internally rotate or externally rotate. These have the most motion of all. Good. Be able to define each type of articulation or joint and give an example and discuss what kind of movement is possible. All right. Now, speaking of these synovial joints, okay, so we're focusing now only on synovial joints. We don't care about that word, right? We're looking only at these fluid-filled, these are fluid-filled, freely movable joints. If you look at your notes, components of the synovial joint. Every synovial joint has to have some hyaline cartilage, has to have a joint capsule, a joint cavity, some fluid inside, and reinforcing ligaments. So let's just go over the basics of what every synovial joint has. Folks, it has to have these structures. That was kind of weird how it did that. It has to have these structures because these are what allow it to be freely movable. So, first things first, we have to have some cartilage lining the end of the two bones that come together. So here we have hyaline or articular cartilage. They mean the same thing. You could say hyaline cartilage or you could say articular cartilage. This is the blue little piece here. You see this blue? It's like a little glove or padding. This would be the hyaline or articular cartilage that lines the end of bone. So in a synovial joint, where those two bones come together, the ends of the bones have a little padding called hyaline cartilage. We have a joint capsule, and then we have a joint cavity. Okay, let's first talk about the joint capsule. Joint capsule. Here it's called articular capsule, but we can also call it a joint capsule. This is the, I'm not sure the best way to say it. This is the outer ring. In other words, this is a fluid-filled joint. So we're going to have something, an outer connective tissue that contains that fluid, that holds it in. The joint capsule, so I don't know what's going to make sense for you, but it's kind of like the outer ring. It is connective tissue, and it keeps the fluid inside of the joint. It's pretty thick connective tissue. Imagine like really thick bands of connective tissue that hold the fluid in. It forms an outer boundary or ring. Forms an outer boundary or ring. Joint capsule. You don't need to know the different layers, just that it's a joint capsule. Outer ring or boundary, thick connective tissue bands that keeps the fluid inside. This is the outer boundary. We'll talk about it more when we get to the joints, particularly when we get to the shoulder, the knee, and the hip. All right, so it holds everything in. I'm trying to think of an example of what it would be like. It's like a thick layer of saran wrap that forms a circle over the joint. We've got to contain that fluid within. Well, the fact that we have that outer joint capsule means that there's space for fluid inside. Let me change colors. I can't decide what kind of color to use. I know these are tough questions. So the fact that we have this joint capsule, this outer connective tissue that holds everything in, means that we have a joint cavity. The joint cavity is just the space. It's a cavity. So we have this outer connective tissue that serves as a boundary, and inside of it is a joint cavity or space. And this joint cavity is filled with fluid. I mean, I think you probably knew that inside are freely movable joints like the knee and the shoulder and all those. We have fluid. What kind of fluid? Synovial fluid. Because these are synovial joints, synovial fluid. What is the function of that synovial fluid? Lubrication. Remember, folks, these are freely movable joints, right? So it's just like a car engine. You have these moving pistons. When you have moving parts, you need to have some kind of lubricant. So in a car engine, it's oil, motor oil. Here, it's our synovial fluid. It makes sure that we don't have a lot of friction, and it lubricates the joint surfaces. And as a matter of fact, this synovial fluid, not only does it provide lubrication to decrease friction, but it also provides some nutrients. So that fluid in itself has some nutrients and some yummy, delicious stuff in there. Now listen, every synovial joint has this. It could be a big one like your knee, but it could also be the tiny little joint at the end of your fingertip. They all have these because they are all synovial joints. Now, working my way more superficially, what we've established so far is all very deep. But outside of the joint capsule is where we have surrounding ligaments. So this is the deepest picture, right? This is showing us the deepest parts of the joint, straight down to the bones. Then we start to move a little bit more superficial, and we can see directly superficial to the joint capsule would be the surrounding ligaments. Here's the knee, right? We got a ligament here. So we have ligaments on the sides, the collaterals. We have ligaments on the inside forming an X. Every synovial joint directly superficial to the joint cavity and joint capsule will have surrounding ligaments. We're going to define a ligament more a little bit later, but a ligament connects a bone to a bone. I just have my notes you're probably hearing to make sure I cover everything that I want to. Okay. And then now we go to the most superficial view. Right? So the deepest was on your left where we saw the bones and the hyaline cartilage and the the joint capsule. Then outside of that, a little more superficial, we had the surrounding ligaments. And then the most superficial, we have muscles. I know it's not on your list here, but I like to show the whole thing. So on your far right here are the muscles around the knee, but I just want you to realize that underneath the muscles are the ligaments. Deep to the ligaments would be these structures. Such good stuff, folks. Here's an actual MRI of a knee, so we can see a lot of cool stuff, right? Here is the femur. Here is the tibia. Here is the fibula. What else can we see? We can see some of the surrounding muscles. This is the posterior side on the back to your right, so this would be the hamstrings. This would be the gastrocnemius, your calf musculature. Back to the bones, this is the patella. The muscle group up top is going to be your quads. Such cool stuff. What if we look at the synovial joint itself? We have the two bones that are connected, the femur and the tibia. There's a layer of hyaline cartilage. Do you see how at the end of here, it almost looks like a little glove? That's a thin layer of padding called the hyaline cartilage. In this view, we don't necessarily see the joint capsule, but we do see the joint cavity. So the presence of the cavity is here in that black open space. So cool. Okay, so from here on out, folks, we're going to focus our discussion on the synovial joints. Synovial joints. These are the freely movable, fluid-filled joints. So now, if you're following along in your notes, which you should be, number 3, types of synovial joints. We are looking only at synovial joints. So, in our synovial joints, we have a ball and socket joint. This should be familiar to you, folks. Ball and socket. What are examples in our body? Hip and shoulder. If you think about the actual structure of the joint, one end of a bone is round, and it fits into a socket. I mean, come on, folks. What motions are allowed here? The most motions. Pretty much every motion is allowed. Exclamation point. This arrangement of just having a free end of one rounded end into a socket allows us to do flexion and extension, allows us to do abduction and adduction, internal rotation, external rotation. We can actually circumduct. Circumduction is to combine flexion, extension, abduction, adduction, internal, external rotation, combined all those three into a circular motion, as if you were a third base coach waving someone home. Okay, just spilled my water all over myself. So for each joint, type of synovial joint, be able to describe how its bony surfaces come together. So in a ball and socket, the joint surfaces come together like one end is a round ball and the other end is a socket. You should be able to give examples in the body, and you should be able to list what motions are possible. Next, we have a hinge joint. The true example of a hinge joint in the body is the elbow. Now, I must make a side note. You know me well enough by now that I can't just leave this the way it is. Later this semester, we're going to have chapters. We're going to have a whole chapter on the shoulder. We're going to have a whole chapter on the elbow. We're going to have a whole chapter on the shoulder or the knee. That's when we're going to get more specific. That's when I'm going to say to you, oh, look, the elbow. It's actually the humeral-ulnar joint. Oh, look, the shoulder is actually the glenohumeral joint. The elbow is actually the humeral-ulnar joint. So we're going to get more specific. We're going to talk about those specific bony surfaces. For example, in the elbow, it's the trochlea of the humerus fitting into the the trochlear fossa of the ulna. But more to come. For now, just know what's in red here. The example in the body of a hinge synovial joint is the elbow. The bony structures are kind of like a door hinge. One end is kind of notched out, kind of like this in a door hinge, and then the other end is more rounded, and it fits in like a hinge. The hinge of a door, it can only work one way, open or close. In the case of a true hinge joint in the body, it can only do flexion and extension. And as an aside, because it can only do flexion extension, hinge joints are said to be working mostly in the sagittal plane. Because doesn't flexion and extension occur in the sagittal plane? All right. Now, I'm going to go back here because I don't think, let's see. Okay. Apologize for moving around so much. I'm going to add one up here because it's not on the screen, but we can talk about it. If you follow along in your notes, I don't know why I put C there. Okay. We talked about the ball and socket, the hinge. Another example in the body is a modified hinge joint. I know we're getting all specific, but these specifics do matter. So that's why you may have caught me saying it. That's why I was saying true hinge over here. The true hinge joint is the elbow. The modified hinge joint in the body is the knee. The knee is mostly like a hinge because it can flex and extend. But the knee is considered a modified hinge because not only can it flex and extend like a true hinge joint, it can also do a little rotation. It can do a little internal rotation and it can do a little external rotation. We're going to discuss this more when we get to the knee. As I said, we have a whole chapter on each joint. Maybe when we meet in person, if you want me to show you what that looks like at the knee joint, the rotation, I can. Most importantly, though, we're just laying the foundation, understanding that we have different types of ways that the bones fit together. The way that they fit together relates to their function and what movements they provide. So for the knee, the body needs it not only to flex and extend, but we also need it to internally and externally rotate. Okay, modified hinge, good. Let's talk about a pivot joint. Now we're at letter D on your notes. The pivot joint has one bone pivoting over another. One bone pivoting over another. One bone pivoting over another, as the name suggests. The best example of this in the body is the proximal radio-ulnar joint. So your radius and your ulna, we know those are the forearm bones. Well, proximally, close to the elbow, this radial tuberosity, okay, the radial tuberosity is this bump on the upper end of the radius, and that radial tuberosity fits into a little notch on the ulna. And what happens is this radius is allowed to pivot over top and then back of the ulna. When we pronate and supinate, it is the head of the radius that is pivoting at this joint. So in this case, what motions are allowed? Typically a pivoting motion, because that's the name of the joint. But we're going to be a little more specific because of our example. At the proximal radio-ulnar joint, the specific name for that pivot motion would be pronation and supination. Good. All right, do I have saddle on here? Yes. Good. A saddle joint as you can see by the picture, I know these are kind of lame pictures maybe, but I think they do a decent job of just showing you how the bones, the shape of the bones fits together. It's probably easiest if I just give you an example of a saddle joint. The best example of the saddle joint would be carpo-metacarpal joint of the thumb. Now, a couple of things that I want to say. This is not the same as your knuckles, aka knuckles, which of course we know has a different name, which we're going to get to, folks, because the knuckles are the metacarpophalangeal joints, MCP. We're talking about the carpo-metacarpal joint. Because I'm not in front of you, here's my thumb. 1, 2, 3, 4. Look at that. So we'll do thumb on this side, right? Your thumb. Your thumb has two joints. There's going to be a joint here where you can just bend the tip of the thumb, and then there's a joint down here. The carpo-metacarpal joint is the lower one. Let me get some green here. This is the carpo-metacarpal joint because it's the joint between the carpals, the row of wrist bones that lines right there, and then the metacarpals I didn't draw this big enough. The metacarpal would be there. Metacarpal. And then this would be the phalange. Okay, it's the second joint down there. That's the best example. Carpo-metacarpal. Joint between the carpals and metacarpals of the thumb. In some ways, it's like a miniature ball and socket. In some ways. So therefore, it can do most actions. It can do flexion, extension. It can do abduction, adduction. And it can do rotation. So it's kind of like a mini ball and socket. But really, the point I want to get across is be able to give an example. Carpo-metacarpal joint of the thumb. Now let's talk about the condyloid. This is another example of a ball and socket, mini ball and socket, but it's like a very shallow mini ball and socket. I'm trying to give you some tips on ways that you can remember how these are different. So when I think about a condyloid joint, I think about it as being a very shallow mini ball and socket. Because I think everyone can't you visualize a ball and socket joint? But this is, a condyloid is shallow, right? There really isn't that deep of a socket here. On the other hand, if I go back to the saddle joint, it's a deeper version of the mini ball and socket. Okay? So it's not quite a true ball and socket where one end is completely circular and the other end is a deep, deep, deep socket. This is like a mini ball and socket, but it's somewhat deep. Whereas the condyloid is a very shallow mini ball and socket. The example of our condyloid joint is that knuckle. But Lord help me, you're not going to say knuckle, right? We're going to use the anatomical terms. Metacarpophalangeal. Metacarpophalangeal. So cool. By the way, now that I have this picture of the hand on the right, a better hand than I can draw, let me go back to that carpo-metacarpal joint of the thumb. It's the lower joint here, right? So on this picture, this is the saddle joint. Now we're talking about the metacarpophalangeal, and that would be this version in digits 2 through 5, what you think of as your knuckle. Everyone knows what that means. But it's the metacarpophalangeal. These, oh, wait a minute. I have this wrong. See? Folks, I'm not afraid to go back let me go back to the saddle. Carpo-metacarpal. And, don't be afraid to do this for yourself, right? Just double check. Say it out loud. Okay. Carpo-metacarpal. Well, these are the carpals. Oh, yeah, these are the carpals. These are the metacarpals. And then the fingers, the phalanges, are out here. So by labeling the bones of the hand, carpals, and then metacarpals and phalanges, I can better understand and label. Because here, it's the carpo-metacarpal joint of the thumb. Joint between the carpals and the metacarpals. Carpo-metacarpal. Great. I mean, guys, the joints are named for the bones they connect. I know it can be a mouthful, but just slow down. Label the bones. Carpals, metacarpal. So the joint between the carpals and the metacarpals is the carpo-metacarpal. This was our example of a saddle joint. But now I want to label the condyloid joint. Condyloid joint, our example would be the metacarpophalangeal. And that would be, let me use a different color. So you put the carpo-metacarpal in green. The metacarpophalangeal would be the knuckles, right? Because it's the joint between the metacarpals and the phalanges. So it's the metacarpal phalangeal joint, and this is an example of a condyloid, otherwise known as your knuckle, but you're not going to say that. You're going to say metacarpophalangeal, MCP. What motions are allowed? Well, it's a mini ball and socket, so similar to the ball and socket, similar to the saddle. Even though it's shallower, the condyloid can still do flexion and extension, abduction and adduction, and internal external rotation. Okay. Excuse me. Feel free to go back, because I'm going to erase this, but feel free to go back to the just earlier part of the video if you want to see that labeled more. Almost done with this. Let's talk about a plane joint. This is our last one for you to know. Plane joint. The best example of a plane joint would be the intercarpal joints, or joint between the carpal, like this joint right here, between this bone and this bone. Intercarpal. The type of motion that's available is more of a gliding. We can't even quantify it as flexion and extension or abduction and adduction. It's more of a gliding motion. And a lot of times it's not perceptible to our naked eye. So they kind of glide a little bit. It's flat surfaces gliding together. Intercarpal joint. All right, that is memorization. Okay, I am going to wait until we meet in person. And I'm making a note as we speak, as I record this. I want to do this in person in lecture, the movement at synovial joints, angular versus gliding. So I'm going to wait on that. Okay, good. Joint stability. This isn't a huge thing. I just want to point out, well, actually, it can be. I was thinking about something else, but actually I do want to talk about this. Okay. So let's first look at bones versus muscle. If you look at your notes here, I'm talking about We're Roman numeral 3, joint stability. Letter A, factors affecting stability. And I'm going to look at number 1, bones, and number 3, muscles. Different joints get their strength or stability in different ways. Now, we know that all synovial joints will have 2 or more bones coming together. They will have a little padding of articular cartilage. They'll have a joint capsule, a joint cavity, filled with synovial fluid, yada, yada, yada. But still, not every synovial joint gets its strength in the same way. To best demonstrate this, let's compare the hip and the shoulder. So at the top, we have pictures of the hip, acetofemoral joint. Then we have pictures down here of the shoulder, glenohumeral joint. Let's compare. If we look at the hip, these are both ball and socket joints, aren't they? We're comparing apples to apples, a ball and socket synovial joint to another ball and socket synovial joint. Excuse me. Which one has more bony congruency? Bony congruency means how much surface area is there connecting bone to bone. Let's look at the hip. Look at how much bone is touching bone. So all this area of blue is the head of the femur contacting the acetabulum or socket of the pelvic bone. But look at how much bone on bone. So here at the hip, we have a lot of what's considered bony congruency. There's a lot of bone touching bone. When we have a lot of bone touching bone, it makes for a very strong joint, a very strong, stable joint. I mean, I'm just putting words to what we already know. There's a big old head of the femur fitting into a deep socket. There's a lot of bone on bone. This gives a lot of bony congruency, bone touching bone, and a lot of stability. We need stability at the hip because we have all our freaking body weight on it. I know, right? We have to have stability. This joint is holding almost all of our body weight. So bony congruency is one thing that influences the joint. The hip gets most of its strength from bony congruency. It will also have ligamentous support. It also has muscles around it. So all synovial joints have bone touching bone. All synovial joints have ligamentous support. All synovial joints have muscle around the joint as well. But we're looking at, what does the hip have the most of? The hip is most reliant on bony congruency. Its ligaments are moderately strong, but the reason why the hip is so strong is because we have so much bone on bone, bony congruency. Let's now compare that to the shoulder. The shoulder has much less bony congruency. Much less bone on bone. If I did the same thing over here, let me use a different color. I only have this much of the head of the humerus touching the glenoid cavity of the scapula. It's like a very shallow socket. So there's not nearly as much. There's much less red line than the blue line at the top. Much less bony congruency. And that means with less bone on bone, it is not as strong or stable. But folks, this is by design, right? The hip has to be very strong and stable because it's supporting a lot of the weight. The shoulder is not very strong or stable because that's not its primary job. So in the building of our body, we sacrifice some of that strength and stability Because what is the benefit? More motion. So in the shoulder, we sacrifice bone incongruency and strength to get more motion, more range of motion. You can do things at your shoulder that you cannot do at your hip. We can't have our cake and eat it too. We can't have all the strength and stability and all the motion. So we take what we need from each. The shoulder, less strength, but more motion. The hip, more strength, but as a result of that, we have less motion available because the socket is so deep. The shoulder, therefore, cannot rely on its bone incongruency for strength. Okay. Those are the two things that I wanted to point out right now. Okay. I am going to, let's see, we have a little bit of time left. Looking at my notes here to make sure. Okay. So let's go ahead and do one last thing, and let's talk about the closed and opened pack position. This is going to be the last thing for this video, and I'm making a note in my notes right here so I know where to pick up when we meet again in person. Okay. So something else that's related, and this is, you may have heard of the other stuff, but this might be something new to you, is to look at, for each synovial joint, there's such a thing as the closed pack and opened or open pack position. You can see I'm really trying to make life as easy as I can for you by giving you some examples. For any synovial joint, we're going to use the knee as an example because I think it's the easiest example. But this is true for any synovial joint. We're using the knee. For the knee, the closed pack position, any joint for that matter, is the position of that joint where we have the most bony congruency, which means that there's the most possible bone-on-bone contact. There's the most bone-on-bone. When we say congruent, bone-on-bone touching. The open pack position means that there's not as much bone-on-bone contact for that joint. Now, each joint we know can only have X amount of bone-on-bone. But for that given joint, its closed pack position is when there's the most bone-on-bone contact. The open pack position is when not all the bone-on-bone is touching. Let's give an example. Closed pack. For a given synovial joint, there's the most bone-on-bone contact possible. Well, we already know when we have more bone-on-bone, isn't there more stability? Just like I said with the hip, when we have a lot of bone touching bone, we have the most stability. But like I said, we can't have our cake and eat it too. So a joint position that gives us the most bone-on-bone contact makes it the strongest and most stable, but it can limit our mobility. On the other hand, an open pack position, because not all the possible bone-on-bone surfaces are touching, we have less stability. But the benefit is that we gain mobility. Because we need both. What good is a joint? I mean, one function of a joint is to connect our bones and give us stability, hold us together, but we also rely, especially in our extremities, we also rely on these joints for motion. So we have to have both. So for the knee, for example, and you need to know this, right? The position of the knee, tibiofemoral joint, where there is the most or maximal bone-on-bone touching is full extension. I know that's kind of weird because it may not seem so, but it's true. On the other hand, the most open pack position of the knee, where there's the least amount of bone on bone is around 25 degrees of flexion. So you could just say a little flexion. Let's go to the picture. When I am in full extension, we know for the knee, full extension is when the leg is straight. There is the most bone on bone in this particular joint. I have the most here all the way to here. I have the most bone on bone. If I was able to measure that, I don't know, let's say that is 10 centimeters, whatever. I'm just making up a number, but it's a lot. On the other hand, when I do a little bit of flexion, right? A little bit of flexion, the leg is not straight. A little bit of flexion really narrows that. So not as much bone on bone. Maybe it's only 6 centimeters. So our leg is strongest. Our knee is strongest in the closed pack position because there's the most bone on bone. And it's the least stable when we have a little bit of flexion. Because as we're going to find out later, we have a little bit of anterior translation here of the femur, and it just kind of shifts things around, so we have the least amount of bone on bone. Now, that doesn't mean that we still can't get injured. There's been plenty of injuries where someone has a foot planted and their knee is extended and they get hit. You can still have an injury, but compared to each other, on the left here is a little bit more stable. Something else that I want to point out that's important, and this is our last topic, bear with me. In the closed pack position, ligaments are the tightest. Another word for tightness of ligament is taut. So in that closed pack position, when there's the most bone on bone, the ligaments are tight. Ligaments are tight. So if I were to draw in, let's just say if I was to draw in the lateral collateral ligament on this side, it's more towards the red line, but it's tight. Imagine it's like really tight. It's pulled tight. And sometimes that can mean that it's more prone to tearing. So what's good for the bones isn't always good for the ligaments. Tight, it's pulled. Like imagine forces on either end here. It's pulled tight. On the other hand, when we're in a more open pack position, we have some looseness in our ligaments. Another word for looseness is lax. The ligament is lax, or maybe you've heard of laxity. There's laxity in the ligaments. Please don't say laxative because that's totally different. So in a loose pack position, it actually loosens the ligament a little bit. It's not quite as tight. And actually, it makes the ligament less prone to tearing. Okay. Last thing to point out is that when we're in a closed pack, there's no gliding. We're going to talk about that on when we meet next, but I'm just pointing it out. When they're open pack, we can have some gliding occur. In case you're wondering, I'll give you some other ones. Here's more pictures to show you how these ligaments get taut. So the ACL, look at this picture. Look at the ACL. It's showing you in full extension the ACL is very tight. But when we're in a little bit of flexion, you see how it's showing you the ACL being a little bit more like this? It's looser. So when we're in closed pack position, ligaments more prone to injury. So I would like you to know that. When you're in the closed pack position, even though the bones are the strongest, the ligaments, because they're pulled so tight, they are more prone to injury. There's no give. So if there's a stress on it, it's already pulled as tight as it possibly can. Let me say that again. When a ligament is really pulled tight, it's already stressed to the max. So if we add extra stress, it has no more give in it. versus in a loose pack position, the ligament has a little bit of give, has some laxity in it, some looseness. So if we add a stress, it has more stretch to give. If you're interested, I'm not going to ask you what I'm going to put on here, but if you're interested, I can give you some examples. The hip, what are the closed pack? Again, you don't need to know these. This is just extra. I do want you to know the knee. Yes, yes, yes. But really quickly, if you're interested, the hip is almost always in a closed pack. Just because it has such a deep socket. So we tend to not talk about it as much there. It's not as, it tends to be considered pretty much always in a closed pack or relatively stable. But what about the shoulder? Just if you want some example, you don't need to know this yet, but the closed pack, it's actually the strongest in slight abduction. I don't know, maybe 15 degrees, so a little bit away from you. We have loose pack of the shoulder above 90 degrees of abduction. So think about all of our overhead motion sports. Throwing a baseball pitch or throwing a baseball in general, throwing a football, swinging a tennis racket over your head, swinging a lacrosse stick over your head. Above 90 degrees, our shoulders just out there in the wind, so much more likely to get injured. Okay, so you don't need to know the shoulder or the hip, just FYI. Listen, folks, study, study, study. We now know about the expectation. The video here, what I do is mostly straightforward, but you got to do the time to study. All right, see you next time.